Hi, everyone, and welcome. We have a very special guest today, Dr. Dua. She is with Mass General in Boston, and she is at the forefront of research on walking as medicine for peripheral artery disease. We've all heard about how walking can help you grow that natural bypass. Well, now we are going to hear exactly the mechanism of action by which this is actually possible and how to do it most effectively.
So let me give you a little bit of background on me. So I am a vascular surgeon that works at the Massachusetts General Hospital. I'm an assistant professor of surgery at Harvard Medical School. I did do my vascular surgery training at Stanford before this in California. And prior to that, my general surgery training at the Medical College of Wisconsin in Wisconsin. So I'm double boarded in vascular surgery and general surgery. And I also have my American Board of Wound Care certification. So I am also a wound care specialist. I'm actually the associate director of our wound care center at Mass General. I am director of our vascular lab, which I know all of you have been to, where you get your ABIs and your ultrasounds and whatnot at Mass General again. And I'm co-director of our Peripheral Artery Disease Center, which is why I'm here to talk to you today. And those other directorships I mentioned are not pointless. They're all related. And that's why I bring them up to tell you that, in order to treat PAD, there's a very particular type of person. And so I want to talk to you a little bit about kind of the different ways that you need to be thinking about the disease, because usually when you walk into someone's office, you kind of hear just one path. And actually, this is more of a conglomerate that you need to be thinking about as you move forward. I did do, as I said, my vascular surgery fellowship at Stanford, where my focus was on peripheral artery disease, and I didn't do too many fellowships beyond that, one in Europe, one in the States, also focused on PAD. So this has always been my thing. I run a vast lab in Mass General, specifically looking at anticoagulation and antiplatelet. All of you guys will be on aspirin, Plavix, Eliquis, blah, blah, blah. They take it away, they put it back, you get a colonoscopy, they take, I will explain all that. And so my lab is focused on that. So at the very end, I'll talk to you a little bit about what we're doing and what we have done, and what the future is that'll, be in store for you guys, hopefully. Just to start out with, so let's talk about peripheral artery disease. Peripheral artery disease, I'm going to start out by saying, is a misnomer, right? It's kind of this label that we stuck on a very wide variety of disease processes and just said, oh, peripheral means leg or arm. Artery means artery, and disease means disease. I mean, if you think about it that way, it's like a billion things. If you get shot in the groin, technically, you have peripheral artery disease. But the fact of the matter is that really the way to think about it is in categories. So peripheral artery disease really is in two giant buckets. Bucket number one is intermittent claudication, which is just a fancy way of saying you walk, you have pain in your legs, you stop, that pain goes away, and you start walking again. Peripheral artery disease in the intermittent claudication sense is not that deadly. It's extremely lifestyle limiting. It can ruin your life, frankly, because you can't leave your house, but it's not going to ultimately result in amputation for most patients. What it is you have a situation where you don't have enough of a pathway for blood to get from your heart to your toes. So that pain that you feel in your legs when you're walking is actually a very normal and very good response of your body. It's your body telling you, stop it. You don't have enough blood flow. You need to stop. You're going to hurt yourself. Okay. Very similar to if you were working out in the gym and you're doing a bunch of reps with your biceps and you get that pain in your biceps when you're working out. What do they tell you to do? What does your instructor tell you to do? Oh, give me one more. Give me one more. Why? Because it's in those moments when you have that severe pain where you're actually going to be building blood vessels. You can do 100 reps like this, no big deal, but it's that last two that build it. Exactly the same physiology in the legs. You can walk for 7 miles, okay? But on that 7.1 mile, when you start to feel the pain, that's when you need to give yourself another 5 to 10 minutes of walking to the point where you're actually limping, because that's where your body is saying, you've got a tribunal basically that sits in your body that has a certain amount of resources. And it has to decide, what am I going to do with these resources? Where am I going to lay down new blood vessels, right? And if you hurt your body essentially by walking, the legs are telling the body, I need you to invest in me and create new blood vessels in me so that I no longer have pain when I walk. It's no different than if you live in a city and you have a city council and there's a crappy road outside your house. The person who goes and complains 1,000 times, screaming and yelling and picketing and chaining themselves to the city council is going to get money to get that road built. The person who doesn't is the one who's going to get nothing. And in fact, they might let the road deteriorate more. And that is what happens when you don't walk, when you have intermittent claudication. Because your body says, yeah, you're in a little bit of pain, but clearly it's not a big deal. We're going to invest in whatever else the body invests in and leave your legs to be what they are. And that's problematic because now, last year you were walking a mile, now you're walking half a mile, now you're walking a block, now you're not making it to your mailbox. And that's a problem because most of you are young. And so as a result, and when I mean young, I mean true, I truly mean that because, the average age now of people who have PAD, you're talking about like the 50s to 80s range, and people beyond that, are living 30, 40, 50 years. It's not right to be in a situation where you can't enjoy your life. And if you're not walking, you're not exercising. And remember, if you have arterial disease, it doesn't limit itself to your legs. The majority of you will have some sort of coronary heart disease as well. And being unable to walk and engage in activity that's physical can result in a stroke or a heart attack that's going to kill you. So it's very important to get you on your feet, so to speak, and moving around. So again, to bring it back to those buckets. Sorry.
It's also good that we are seeing younger people with it because in a sense, it is developing younger, but the problem was that it wasn't being diagnosed soon enough. And now we're seeing more people getting diagnosed in the intermittent claudication stage where they can actually make those critical lifestyle changes and do something about it sooner rather than later.
Yes, absolutely. And I'm going to hit you guys hard with the critical lifestyle change in a second. That might seem a little jarring, but it's got to do with building those new blood vessels. So in the intermittent claudication phase, when you have a situation where you do not have wounds and you do not have what's called rest pain, where you're just sitting there in your chair, but your leg hurts a lot. So you're not in that category. That's bucket number 2. That's critical limb ischemia. So we'll get to that in a second. We're just talking about purely here, it hurts when you walk, whether it's 5 steps or 100 steps, it hurts when you walk. That's the intermittent claudicant. That patient can really, really turn their life around by walking. Now, how do you do that? This is how you do it. You wake up in the morning every day. You commit yourself to 30 minutes of continuous walking. But here's the ticket. It cannot be, I go for a walk with my spouse, down a couple city blocks, stopping to pet someone's dog, stopping to check if they're fresh avocados. No. Every time you stop, the clock restarts. So what you would need to be in is either in the mall or on a track where you can continuously walk. Because you need to turn that watch on. So you got your iPhone or whatever you have to time yourself. You turn on the timer and you start walking. And I don't care if you walk 7 steps or you walk 7 miles. You document. I walked this far today in time, right? Before the pain set in. And then you document, I walked this much further with the pain, because that's what I need to know. I don't care how far you walked. I want to know how far did you walk when it hurt, because that is what's building those blood vessels. Most people will stop walking when they're in pain naturally, right? And so, and a lot of doctors will tell you even to do that because they don't know. They don't want you to get injured. Your PCP may not know. Or they say, they're scared you're going to fall. You're on blood thinner. You're going to hit your head. People are not going to fall. They'll just stop when it gets unbearable. If you get one of those little chairs that you can flip out and sit down, that's ideal, because then you don't have to go somewhere to sit down. One of those little, like a couple pounds, nothing big, little strap-on chair. You sit down, and the minute that you can go again, you go again. And you do that for 30 minutes and you document each time. How far did you walk? How far with pain? How far did you walk? I guarantee you, I will give you this in blood writing, okay? That if you do that in 6 months, you will increase your walking distance and decrease the amount of time that it takes, basically, that you have to sit down, essentially. So you'll be able to walk further with less pain. And that's what this whole creating new blood vessels is, because what's happening, the city council in your body is building that road for you. And you have a little piece of blood vessel down in your ankle, a little piece of blood vessel up top, it makes the connection for you. So it doesn't open up what's already gone. It doesn't do that, but it does create these new connections for you. Are you going to be able to run the Olympics? Unlikely, but are you going to be able to enjoy your lives? go out to the mall, go to a movie, walk around, do what you want with your grandkids? Yes, you will. And all with avoiding a bypass or avoiding a stent. Because getting a bypass or a stent, basically it's like your virginity. It's a one-shot deal. As soon as someone intervenes on you, it's lost. And now you get into a whole cycle of, now I have a stent in my body. I got to keep that stent open. If that stent goes down, you no longer get to be an intermittent claudicant. You switch over to the bucket where you could get wounds. You could get an amputation because now you've had an intervention. So the goal should be to try to stay away from that as long as possible. Now, if you've had an intervention, it's not doom and gloom. It's just that now you have a different set of problems because you've got that intervention. So if you can avoid it, you should avoid it. And the best way to do it is this. Now, walking is one big piece of the pie. It's the only thing that has level 1A evidence, as in randomized controlled trial, highest level of evidence in the world to say that if you walk, you will be able to increase the blood vessel collateralization, which is what that's called, creating those new networks, and you will be able to walk further with less pain. But it has to be done in conjunction with one major thing, and that is if you smoke, you cannot smoke anymore. And the reason is because all doctors will tell you, I don't like smoking, but that's kind of a thing, all doctors say. In vascular surgery, it's especially important because there is a chemical in smoking, unfortunately, regardless of what type of cigarette you smoke, that actually murders the little new baby cells that are created, that are laid down in order to build those collaterals. So think the city council comes and builds a new road. They lay a bunch of tar out there and a bunch of delinquent kids come and jump in it and ruin it every time that the city comes and lays something down. That's what's happening. So every time you smoke a cigarette, a baby cell dies. And you can shorten that to every time you smoke a cigarette, a baby dies. And then maybe it'll stick with you that you won't do it anymore. I know it's very difficult. I don't smoke, but I do have a very severe Diet Coke addiction. And so I know how difficult it is to cut down. And I don't know what I would do if someone told me I, would have to trade one vice for another. And it's painful. So because it's painful, you then smoke. So it's like this horrible cycle. I get that. I'm not here to judge on that front. I'm just saying that it doesn't work to do all this walking and then murder all the baby cells by smoking a couple of cigarettes because you had a good day and you want to take a hit. I'm not going to say anything on a recorded line, but, smoke other stuff. Okay. Don't smoke cigarettes. So that's number two. There is a whole push about diet. Of course, if you shouldn't eat fatty foods because that lays down the plaque that forms in your arteries. But the fact of the matter is a lot of the damage that has already been done to your vessels was done 30 years ago, 20 years ago. So am I going to tell you, I'd rather that you walk that however much on the track and then you have a huge Cinnabon at the mall, than smoke a cigarette. It's not going to ruin anything for you. You may have other problems from eating not healthy, but in terms of building down blood vessels or hurting the blood vessels you've built, eating whatever you want isn't going to affect that. It's the big thing is smoking. A lot of what's going on with you guys is actually genetics. It's not your fault. It's mom and dad's fault, as with a lot of things in our lives. And so, and that's where my whole lab comes into things, because we're looking at personalized medicine. Is it right that, this person gets this same drug as another person? No. And is it right that you all have the same treatment? No. In the same way that if someone, two people can have breast cancer and have completely different treatments because they are, even though it's breast cancer, it's completely different pathology. And PAD is the same thing. It's a heterogeneous thing. It's not the same for Kay, for example, as it is for Joyce. But at the same time, there are some tenets that if you follow, you will overall have better outcomes. So this is in the PAD world. So walk, do not smoke. You have to actually take notes on this, because if you don't, you won't realize. In the same way that if you gain or lose weight and somebody sees you at a Christmas party and they're like, wow, you've lost all this weight, and you're like, I think I look the same, because you see yourself every day. So similarly, you're walking every day, you're not going to notice that you're walking another 4 minutes without pain. But if you document it, you will see it live, and that in and of itself is a lot of validation and will push you to do more and more. So that's a big deal. There's really no endpoint to it. Unlike cardiac rehab, if any of you have ever been through that, there's an endpoint. You do 6 weeks and you're done. PAD does not work like that. You have to continually push with it. It's tough. I live in Boston. Obviously, people can't go walking outside. So it's hard. I mean, you do have to go to a particular location, and it's sort of God's cruel joke that in order to treat a walking disease, you have to walk. But in a way, it's also poetic, isn't it? that's forcing you to do something. And so I'm here to tell you that that's how you do it, and that you're not going to hurt yourself when you do that walking. So don't be worried. Go ahead and do it. Now, let's talk about critical limb ischemia. So critical limb ischemia is different. Critical limb ischemia, again, PAD is the big umbrella. Underneath it, 2 buckets. Bucket number 1, intermittent claudication. Do the walking. It's not going to hurt you. A very small percentage of people, about 5% of people who have intermittent claudication, go on to get an amputation. So it's extremely rare in that subgroup of people. Okay. Now, critical limb ischemia is a different story. Critical limb ischemia is when you have a wound on your leg, okay, your foot specifically, or you have rest pain. Your foot is red, hot. It's very painful. You can't even put it down. You wake up in the middle of the night, leg is in severe pain. People in that category are at major risk of amputation, especially with diabetes, and need some type of intervention, at least with a vascular surgeon. Walking it off is not going to work in that group of people. Now, the thing is, though, what's confusing is wounds form for many reasons. Wounds form essentially for 3 big reasons, though. 1 is bad blood supply. Number 2 is pressure. You got the wrong shoes. You know, we've all, when we were younger, you know, wearing the wrong heels, you get a shoe bite, right? Within one night, you get the shoe bite. So pressure. And number 3 is infection. And the worst situation is a combination of these 3 things. Now, if you have a wound because of pressure, that's a whole different story. You need diabetic shoes, you need a podiatrist, and you're not at risk of the leg being amputated unless it gets broken down and infected. But if you have peripheral artery disease and you actually have a vascular problem, the flowers are not getting watered because there's not enough water. The cells are not growing because there's not enough blood. That's where you need an intervention. And that intervention can range from a simple ballooning of the artery to get you more flow, all the way through to a distal bypass, where they're taking vein from one leg and they're making, not they, are making a connection between one blood vessel and another blood vessel. And so what's really important is, regardless of which bucket you fall into, you should have some type of interventionalist seeing you to be able to monitor you and make sure that, first of all, you're appropriately diagnosed. So if you do have a wound on your foot that is an ischemic wound, as in not enough blood supply wound, we need to know what are your ABIs, which is the pressure of your ankle compared to the pressure in your arm, because blood pressure in your nose should be the same as blood pressure in the tip of your toes. And I'm sure all of you have had that test where they do the little like blood pressure test of the ankle and the blood pressure test of the arm to compare. Is it the same? And if it's not, which it isn't in people with PAD, how bad is it? What percentage of the pump from your heart is getting to your toes? Because if you think about it this way, if there's a boulder in your groin, if there's a boulder behind the knee, that bolus of blood that's going down there will be stopped at the groin and stopped at the knee. And so only a small percentage of it will make it to the toes. And as a doctor, I can quantify that. I can say, oh, okay, you know what? 50% of her blood supply is getting to her toes. But in diabetes has a predilection for eating the itty bitty blood vessels of the feet as well. So you may have okay blood supply to your ankle, but crappy blood supply to a wound on your toe. And that's where we really get into fancy things in order to be able to get you blood supply down there. We do some very cutting edge stuff here at Mass General specifically, where we shunt blood from one blood vessel to another and do other things that can help you potentially. But really, you shouldn't even be talking about that if you're in the intermittent claudication category.
Right. They're very familiar. We've talked before about the pedal loop. We've talked about deep vein arterializations, but
yes,
really as a last resort, limb-saving effort, the doctor says amputation, get a second opinion from someone who has either one of those skills, who could at least, if you're going to amputate anyway, what do you have to lose than to let someone at least try with those Hail Mary efforts?
100% agree with that. And I think, a lot of it has to do with the way the world works. This PAD is getting a lot of attention now because diabetes is on the rise like crazy. It is an epidemic now. It has always been a problem, but unfortunately, this disease did not get the attention that it needed to get because it's too helter-skelter. There are too many different types of people. You think of somebody who has breast cancer, a patient comes to mind, not in terms of race or anything, but like in terms of who is this patient? What type of life do they live? We hear about the marches and the walks and Congress is passing a bill for this and that. You never hear it for PAD. And actually, if you look at the numbers, I'm actually making a talk because I'm giving a grand rounds on this just in a couple of days. It is craziness. The number of patients that are getting amputated for PAD surpasses all cancers combined in terms of deaths. It's shocking. And yet it doesn't get, but you guys know that. I mean, know it more than me, even from living that's not the way the government works, right? It doesn't focus on what's actually, it's political. But that's where new doctors and a new generation of people, regardless of whether they're vascular surgeons, interventional cardiologists, or interventional radiologists, people who are interested in PAD and taking care of the PAD patient. Because it's a complex situation where you have intervention, you have wound care, you have vascular lab, you have medicine, heavy medicine, because we've got to control your diabetes. HbA1c has to be down, has to make sure that you're on the right blood thinners, and have to make sure that your lifestyle changes are appropriate for you. So there are doctors out there like that. And it's important for you to be exactly like you're doing, educated on this disease, so you can tell when you're in front of a doctor, yeah, this is someone I want to be with, because this is going to be your partner. It's like a marriage, because your PAD is going nowhere. There's no cure. So you're going to be seeing this person for the rest of your life to be monitored. And a good surgeon, a good doctor, will also look at your carotid arteries and look at your belly to make sure you don't have aneurysms, make sure your heart's okay, make sure your carotid's okay, because if your disease is in the legs, it's also everywhere else. Because it's not about just keeping the leg, it's also about keeping your life, right?
We always talk in our network about chat, carotids, heart, abdomen, toes. So every time you go to the doctor in your annual checkup, let's chat, doc. C, carotids, H, heart, A, abdomen, aorta, and T, toes. Let's check the blood pulses.
I like it. I'm going to steal that.
I might even have an infographic for you. So I wanted to also, let's bring in nurse practitioner Kay Smith really quick, just before we go into those questions, and talk a little bit between the two of you just about how to walk when you have one of these non-healing ulcers. How can you prepare yourself? What are the questions that you should be asking your doctor? I think there's Kay.
Yeah, I'm here. Hi, Dr. Dua. Yeah, we've got a few patients here. There's some online as well, and they've had really serious tissue loss, ulceration of the toes, and they've still kept persevering and tried to build their collaterals. Some of them have had iliac stents done and still lack a blood supply. And basically my job is to advise them as best I can. I prefer natural therapy in wound care. So I'm a big advocate of Medi honey and Manuka honey, etc., to be more tender, especially in the elderly patients as well. I don't like using iodine, etc., because it can actually burn the flesh. When it comes to walking, I'm the perfect example. I got PAD. I didn't know it. I was diagnosed with a severe back stenosis, 2 slip discs, and put in a wheelchair. And I was in that wheelchair for nearly 3 years.
Oh my God.
And I reached out to, my toes went blue, and I was sent to a vascular surgeon. And he said, oh, you've got PAD. We'll take you in and we'll do a wee procedure. We think it's just your iliacs. He got as far as I anesthetized, because I also have lupus, and the lupus has caused diabetes. So there's a big long story there. But the gist of it was, when I got my procedure, he couldn't get through my aorta, and he didn't have the skill set to get through my aorta. So he marked me off as palliative, told me to sit back in my wheelchair, phone my husband, come and take her home. There's nothing more we can do about her. And that's when I reached out to Kim. And I watched people like Monica's here, Douglas is here, and I watched everybody getting off the backsides and walking. And all I could manage was a few shuffles to the toilet, or going from my wheelchair onto a stool in the kitchen to do prepare a meal. I then decided that I would enter one of the challenges, the walking challenges that Kim was running. And it was for 28 days, 1 month. And I got out that wheelchair. And I think the first week, I only got 197 steps or something in. But by the end of that month, I hit 3,000 steps. I think 3,400 steps. Now my blockage was abdominal. My blockages are predominantly caused by, they're not typical PAD, they're predominantly caused by autoimmune diseases. But I suffer the same symptoms as everybody else. I've had a procedure. I have my stents. I have 2 iliac and 1 aortic stent, but I still have a blockage in my CFA going down to my anterior tibial. Not because it's not a blockage, that's the wrong word. They were resting for so long that they haven't opened yet. So my surgeon is hoping that they open, but if they don't, he's going to go nice and low and slow and just open it back up for me. So I'm still having intermittent claudication. But when it comes to wound care and it comes to people in wheelchairs, they're stuck. And they can't get up, but if they do get up, we have a coach and we do chair yoga to start to stimulate them and get them moving and get the feet moving, the rolling a tin of beans about the floor, etc. And it's really important that patients are motivated and continue to be motivated to do those exercises, even if they are unable to actually walk due to wounds or due to a wheelchair. I use, as I say, I recommend Manuka honey. I recommend foam dressings, especially if the wound's on the heel. There's some nice foam heel pads that are available that can actually protect the heels. So before your wound actually breaks down, or heel breaks down, we have a lot of patients with dried out heels and they start to get hacks. There is nice heel pads that they can put on. I recommend heel balm, etc. The most important thing is to offload those feet for the pressure. As a nurse practitioner in wound care, the pressure has always been a focal point for myself. So I will recommend the shoes, offloading insoles to make sure that they've been to the podiatrist and their diabetologist or endocrinologist if necessary, and they've got the correct footwear. And I also thoroughly recommend diabetic socks for all PAD patients, because then the normal sock has a ring of elastic around the top of it to hold it onto your legs. And I find that actually can cause a lot of circulation problems. So I recommend diabetic socks to anybody with PAD, not just a diabetic. How do you feel as far as wound care is concerned, and my recommendations with honey and soft foam dressings and offloading?
No, I think that's fantastic. That's exactly what I would say. I mean, the biggest thing is the offloading, because and I think, the way, at least that I think of wounds, is I think of wounds as a symptom, right? If you have a cough, you could have COVID, you could have lung cancer, or you could just have inhaled some smoke, right? It's a symptom. So you don't treat a cough. It doesn't make any sense. You treat the problem. What's the underlying issue? And the thing with wounds is that, the problem with wounds is they're in your face. You go to a doctor, you pull off your shoe, you got a wound, they're looking at your foot and they're like, oh, we should XYZ to the foot. But the problem may be way up here in your belly. You have a blockage, And I think, so the biggest thing with the wound is, why do you have the wound? Somebody needs to give you an intelligent reason. And it has to be one of those 3 things I said. Offloading, as in a pressure issue, blood supply, or infection, or some combination.
Yeah.
And I'm very aggressive, as in, like, if somebody has a wound that has like a diabetic foot wound, there's no messing around with that, because that can end in an amputation. you are on antibiotics aggressively, might even have a PICC line to get those antibiotics for 6 weeks. You might get casted by the podiatrist so that you don't have pressure on the wound, and a intervention potentially to get blood flow to your leg if you don't have enough flow, in different locations. And so I agree with everything you said. I think that's spot on and right down the right alley.
I'm speaking predominantly from a UK perspective, but it's also something that I'm seeing in the US. So I hope you don't take offense, but there seems to be a lack of continuity of care. So they've seen the vascular surgeon, but then the wound care side is not taken care of. So there's a gap between the matches.
God, yes.
And that gap is the most dangerous period of all.
I couldn't agree more.
Yeah.
Couldn't agree more.
We've had way too many of our ped warriors here who we get them revascularized, they go to the podiatrist, and then there's no one to follow them in between.
Yes.
Even the home care nurses are actually not board certified in wound care.
Nope, correct. We know. That's where, so I knew you were going to say something about the UKK because I went to medical school at the University of Aberdeen. So I'm actually Scottish. Weirdly. But I was born in
a lot of work in Aberdeen. So, yeah.
Oh, really? Okay. Yeah. I was an ARI that's where I did my medical school years ago. Like
one of the best interventional radiologists ever was Jeff Hussey. If you were there when he was there.
Oh no, this is no. I was just in the medical school, so I
Oh, you're a baby.
Yeah, I was just trying to skip class and talk to boys. So, but the thing about that, so you couldn't be more correct. So Mass General Hospital, Massachusetts General Hospital, Beacon World, blah blah blah, world renowned, whatnot. That hospital did not have a comprehensive wound care center. Remember I told you guys earlier about PAD not getting the respect that it needs to get? This is a classic example, okay? Classically. So a cancer patient, again, and I bring this back because it's such a perfect analogy. If you have a breast cancer, right? In order to be treated properly, get the best care, longest life expectancy, appropriate surgery, appropriate meds, you need a medical oncologist. You need a person who's coordinating all your care like a PCP. You need a tumor board that's going to talk about you and make good decisions surgically versus medically. And then you need that comprehensive care. And there's no time to spare. You need to go for radiation therapy, and then immediately after that, get your surgery, and then immediately after that, get your chemo. And if you've got any big breaks anywhere, you die, right, from metastatic cancer. So similarly with PAD, it's exactly the same phenomenon. You can't just get the cancer surgery without getting the cancer treatment, which would be the wound care appropriate treatment. But right now, because of the way in which the world works, there are very few places, though it's becoming more and more the thing, to have comprehensive wound care centers. So at Mass General, we have something called the LEAP program. LEAP stands for Limb Evaluation and Amputation Prevention Program, as in MGH LEAPS. When I was at Stanford, we had the STEP program, something similar. And for example, at Mass General, we have a podiatrist, a wound care specialist. We have a nurse coordinator, who's the heart and soul of it, myself, and a number of other interventionalists. But the point is, it's a system. It's like an ecosystem that a patient enters and then gets all the care they need coordinated by one person. What's the point of seeing you in the ER, fixing you, but your blood sugar is 1 million and you don't have an endocrinologist? Yeah. How are you going to heal that wound? You'll never heal that wound. Not all the meta honey in the world. You could drink it. It's not going to help you because your blood sugar is 600. So we know that. And what's happened, unfortunately, is amputation rates and wound care rates are not monitored by the government and whatnot to say, hey, if you, as a doctor, this is the standard of care. If you see these many PAD patients who have this type of disease, your amputation rate should not be higher than X number. If you did something like that, a metric, now suddenly people are held to that standard. And that is the fundamental problem. There are no standards.
Yes, I agree completely.
And
even in the UK.
And even in the UK, that's right. And a lot of it has to do with the difficulty of the coordination of care.
Yes.
Not all patients are like you guys here, listening, understanding. A lot of patients are like, I don't know what's going on. And that makes them even more vulnerable.
Of course.
A lot of patients are elderly, even more vulnerable. So, my advice in that realm is, you really should be getting care at a comprehensive center. And if you aren't in a location that has something that is comprehensive, then the best thing that you can do is talk to your physician, who then becomes your point of contact and needs to get that taken care of for you. Don't let anybody have the honor and the privilege of touching your body and doing surgery on you without doing all the rest of the stuff, right?
Yeah.
That's not good enough.
Yeah,
I'm running through some of the questions that people should be asking their wound care specialist before they go into walking. And Dr. Dubois, if you want to chime in as well, I'll let Kay get started with just a few of the questions that are really important.
Please do.
Yeah, I mean, straight after your procedure, one of the first questions is, how soon can I start walking? That's one of the first and most important questions. And most people can start walking again after a procedure within a few days. I think the next day after I had my procedure, I did about 1,500 steps, which obviously was amazing, just that 24 hours later. That's one of the most important questions. The other question is, what support is available for you? Do they have, in the UK, sometimes they'll give you a gym membership to help you, and that gym membership is for 3 months. I don't think that's available in a lot of places in the USA, but there is rehabilitation programs in the USA that have to be recommended. And then there's the place that I found where I could get the best advice and the best support, and that was the way to my heart, and finding this support group. And the walking program that we have, where everybody encourages everybody, and regardless of whether you've done 78 steps or 7,800, it doesn't seem to matter. Everybody keeps supporting everybody else. But regardless of how you approach it, whether you buy a treadmill, whether you go to the mall, as you say, we don't have a lot of them in the UK, but they are there. And whether, no matter which way you're getting your steps in, as long as the steps are getting done, and as long as you're starting to get back on your feet and to keep your pad at bay, and making the lifestyle changes as well seems to be a big one. A lot of people seem to think, well, I've got my procedure now, so I'm okay. I can go back to smoking, I can go back to eating what I like, and they don't seem to take the whole picture. And that's what I like about the Way to My Heart, because we support people for lifestyle changes, including diet, especially for stopping smoking. And that's something that you need to ask your doctor what's available to help you. If you've got a wound on your foot, you need to ask your doctor for a recommendation to a wound care clinic, to what dressings to wear. For offloading, it's available on prescription for offloading shoes and podiatry shoes in the UK. Unfortunately, I think you have to pay for them in the United States. So does insurance cover them, Kim?
That would be a question, probably depending on the insurance, but some do cover them, yes.
Yeah, okay, thank you. So you get yourself the offloading shoes, whether they're outdoor walking shoes or whether they're slippers or shoes for within the house, something that will offload your weight and make sure that there's no pressure on your feet. The other thing to ask your doctor basically is pain control, and this is a major problem in the UK, in the USA. Pain relief. As you say, there's other things that you can take that we can't discuss. Personally, that's not an option for me. I am allergic to all painkillers. So I actually use virtual reality to get rid of my pain. I don't know if it's anything you've ever heard of, but it's just been licensed by the FDA in America. And you can use a virtual reality headset and actually do something that takes you off on an adventure and takes your mind elsewhere so that you don't think about the pain that you're going through.
That's actually a really important point that you missed when you were saying that you got out of your wheelchair. We actually have pictures and video of you using your VR headset to actually get out of your wheelchair and start taking steps around the living room.
Yeah, I was lucky enough for the VR headset that I was gifted. Basically, it creates a barrier. So you create the barrier right round yourself, and my husband moved some furniture out of the way. I could create my barrier, and that meant that I wasn't banging into furniture or falling over or tripping over a piece of furniture. I could then walk around with my headset on, using my handpieces, reaching out. I use scuba diving a lot, or I can go in safari, or I can do basically anything that I've ever fancied, like walking about the cherry blossom gardens in Japan. It's the first day of spring. I know there's a certain person on here that likes to go and become a fighter pilot using his VR headset. But it's anything that takes your mind off the pain.
Yeah.
Pain is a big, big factor in all of this, because if you're in pain, you don't want to walk. If you're in pain, you struggle to get up, to get out, and to actually motivate yourself. So pain is a major issue. I don't know how else everybody else copes with the pain in the US, but you have my complete sympathy, because I know it's very limited what you can actually get.
Hey, Dr. Duat, how do you help your patients manage their pain?
Yeah.
It really depends on what type of pain it is. You know, a lot of my patients, unfortunately, have mixed pain, because they have not only the pain from the wound itself, or the ischemic pain, which is actually some of the worst pain in the world, because it's like choking on the leg, but they have neuropathic pain. That is, you know, a combination of the diabetic side of things in conjunction with the wound. Usually with the patients that have neuropathic pain, I will have them start on gabapentin and really ramp up the dosage. Some patients it absolutely doesn't work for. It's amazing. I mean, there's no explanation. Some people it's like, you know, night and day, and some people it makes no difference. In the case of other groups of people, I will have them start on something to basically get the deep muscle and tissue pain gone by having some type of intervention to get more blood flow, because again, the pain is a symptom, right? Like it's caused by something. Occasionally, yes, it can be because a bone piece is exposed or something's actually rubbing that shouldn't be doing so. But if that's the case, then all the more ideally you'd get some intervention to be able to take that nidus away. In terms of just like the deep, boring pain where patients can no longer handle essentially living in that sort of pain, and there is nothing that can be done for revascularization, I actually talk to those patients about amputation, because at that point, if there's nothing that can be done and an amputation would allow them to go on to get a prosthetic where they can move on with their lives, then I get them. And I always ask the question, is this leg running your life, or are you owning this leg? And if they say the leg's running my life, I then say, okay, let's talk about the pain. We discuss where it's coming from, what specifically, and if something can be done about it, intervene immediately. What I don't do is hand out oxycodone like candy, because then they get addicted to that. And it's so problematic, because now you get the stamp on you, you know, because the system is broken again. You know, you get a stamp on you saying, oh, this is a drug seeker patient, as if, you know, asking for meds. Then they stop returning your phone calls from the office and like do all kinds of other things that are really not acceptable. And it's really their failure because they didn't manage the pain appropriately. The other thing I'm very careful about is also deciphering specifically if the pain is coming from, because it's not uncommon for people to have slip discs and to have other issues that are causing the pain. It doesn't have to be ischemic. And so I look into that and ensure that the right thing's going on. And if it can be anything from getting you to see an orthopedic doctor versus getting an MRI of the back, but something to really, at the end of the day, say, this is why you have pain and this is what we can do about it. And then act on that.
Yeah.
Yeah, there is a difference between the feeling of back pain and the feeling from can you describe it? I know Kay can as well, but we see that a lot. And we just had one of our pad warriors that was told, actually, a hospital doctor was going to amputate below the knee for something that actually turns out was not even an issue of the blockage. It was coming from the spine.
Oh, yeah.
And from that, we got the revascularization. Well, still the problem turns out it was lumbar related, but this hospital doctor was going to amputate below the knee for something that was not even vascular related.
I wish I could respond with horror. I'm so used to hearing that sort of thing, you know, because those patients will find me and then I'll be like, let's just take care of you. I will say this is a good little test you can do. Okay. If you think that you might have something going on with the back versus the pad situation, you go to a grocery store, you get a shopping cart. All right. And you actually put your hands on the shopping cart and lean forward, like you're putting your body on the shopping cart, like to take your weight. and then start pushing that shopping cart around, picking up groceries. If you can walk, right, and the pain doesn't set in, it's your back. And the reason that that works is if you lean over a shopping cart, you stretch those lumbar vertebrae, right? Like think of like a shrimp, like how a shrimp is fixed, and it stretches the vertebrae that allows the spinal cord space to breathe. But as soon as you stand back up again, you go back into whatever painful position you're in. So people, I always ask, if you go to the grocery store and you lean over, and people notice this, it's such a big thing. They notice this, that when they get into that position on the shopping cart, the pain goes away. If it does, it's your back. If it doesn't, like, I mean, if you respond by saying something like, I don't go shopping because I can't walk 3 steps, it's probably PAD, you know? But
I mean,
that is a good litmus test.
My doctor actually said to me, can you tell the difference between your back and your claudication? 100% I could tell the difference between the pain at rest and the back pain. And he said, I can take away the rest pain, but you're going to be left with the back pain. So I can't cure you.
That's what I tell patients too.
And I can now tell you that I can feel my back pain more because it was overshadowed by the pain at rest.
Yeah, of course.
Yeah.
That happens with each leg as well too. If you've got 2 legs that hurt, and you know, the doctor should never be intervening on both at the same time, but let's say they do the right leg, you'll notice the left leg will hurt more, not because it actually hurts more, but because you no longer are fixated on your right.
Yeah, it's true.
It's also a very common phenomenon.
Yeah.
Also, the thing with the back is the back has one point, your back. And so people with back pain tend to have pretty equivocal, maybe one side slightly worse than the other, but they really have equivocal pain down both legs. Whereas with PAD, you will clearly see a differentiation between one side versus another. There are people that have claudication that's similar, but
yeah, unless it's your abdominals. Do you not have it in both legs? Because I did. It was my iliac and my aortas.
Oh yeah. So if both of your iliacs are equally diseased, but imagine that, I mean, the chances of them being exactly like, and I actually say it to patients, I'll say, if I have a gun to your head, which side do you want me to do? The right or the left?
Yeah.
And then they'll say, yeah, my right side's the one that starts first, you know?